Hi everyone. Today I'm going to teach or say about the treatment guidelines of hypertension. So generally speaking about the hypertension, I'll be saying about the guidelines regarding the essential only based on the Joint National Committee 8 guidelines, that is JNC 8 guidelines, which is said to be the gold standard used in hypertension. So yeah, first coming to the basics, I'll start from the beginning. What is the blood pressure? Yeah, what is blood pressure? That is elevated blood pressure. Normally blood pressure is something when the blood is pumped from the systolic. There is two types of blood pressure again, that is systolic blood pressure and diastolic blood pressure. Where systolic is when the left ventricular will contract and the blood pumps out to the out of the atrial, right? Aorta. That is when the pressure which is seen that time is the systolic blood pressure. Then again the blood pumps back to the heart from the other part of the body. That is when the systolic blood pressure dips back to a trough level. That pressure is called diastolic blood pressure. So what is the normal blood pressure? 120/80 mmHg is a normal blood pressure which we see. So what is hypertension? Hypertension is something where there is an elevated blood pressure. So it can be elevation of systolic blood pressure alone or elevation of diastolic blood pressure alone or both. That is hypertension. Okay. So what are the types of hypertension generally? There is a primary hypertension, there is secondary hypertension, and there is something called white collar hypertension, and then hypertensive crisis. So essential hypertension, so majorly when you see a patient here, you will notice an essential, that is a primary hypertension, because the epidemiology says that around 90% of the patient who is diagnosed with hypertension will have a primary hypertension. Okay, so the secondary hypertension is related to some other disease present. Because of other comorbidities you will see hypertension, that is secondary hypertension. Then coming to white collar, that means when the patient will be normal in the day-to-day life, when he goes to the doctor, when he sits there, when they will check the BP, then the blood pressure will be elevated. So that is something called white collar hypertension. The interesting fact of white collar hypertension is that studies or the prevalence says that white collar hypertensive, the patient who has white collar hypertension can progress to the primary hypertension and has increased cardiovascular risk. Okay. Now coming to the hypertensive crisis, that is the elevated BP above 180/90 mmHg. So in that case there are two types, emergency and urgency, where emergency is with the end organ damage, and urgency is without any damage. So these are the basic classification of hypertension. And based on the BP you can classify as normal, then pre-hypertension, that is 130 to 139 systolic blood pressure. This is 80 to 89. Then stage 1 hypertension. Stage 1 hypertension is greater than 140 but less than 160 mmHg. And 90 to 99. Then this stage 2 hypertension is greater than 160/100 mmHg, that is stage 2 hypertension. So when a patient comes with stage 2 hypertension, that means you have to start with a combination of two drugs. In case of pre-hypertension, it's again contradictory, like you can just go with the lifestyle modification or you can start with any monotherapy. Okay, so in case of stage 1 hypertension, you can just start a monotherapy with the lifestyle modification. So yeah, I spoke about blood pressure. So it is usually less in the night time. It has a peak rise in the early morning, and around till the afternoon, till the early noon, the BP will be in the higher side, that will be elevated side. Okay, that is the normal in the body. It's the normal thing. Then say I'll talk about the pathophysiology of the hypertension. So usually it is unknown, to be frank. When you talk about primary hypertension, that can be various reason. So before that, I want to talk about a mean arterial pressure. So mean arterial pressure can be considered as BP. It is the formula is 1/3 of systolic blood pressure plus 2/3 of diastolic blood pressure. Okay, so this is the mean arterial pressure, which is used. It is useful in case of hypertensive emergencies and all. We use it. So why I wanted to say about this is another formula is, what is mean arterial pressure? Another formula. And have anyone have idea? Okay, the cardiac output plus peripheral vascular resistance, total vascular resistance or peripheral vascular resistance. So this is important to know the what do you call pathophysiology. So many cases there will be increased cardiac output. It's product. Okay, I'm sorry. The increased cardiac output leads to the increased mean arterial pressure, that is BP. Okay. Another thing is increased total peripheral resistance also leads to the increased BP. So when will the cardiac output increase, or when will the total peripheral resistance increase? Yeah. So there are many reasons that will come in. Actually, secondary hypertension, this fluid overload or some other heart failure issues and all comes. So generally what happens is that there is for the normal cardiac output or proper total vascular resistance, you will have a sympathetic nervous system. Nervous system, epinephrine and all. There is you know about beta blockers, right? So there is a beta alpha and a beta receptor in the body, in the heart, which is important to maintain the cardiac output and cardiac output. Okay, so this is where, so if you know about this, then you know that alpha beta blockers, so this is when beta blockers can be used for decreasing the blood pressure by decreasing the cardiac output, so maintaining this blood pressure. Then comes the RAS, renin-angiotensin system. This is see, when you know about this, right? Renin is released when there is a decreased renal blood flow. The kidney thinks that there is a decreased output, there is a low what do you call a flow of blood, so it thinks that I need to release renin so that I want to increase the BP and increase the blood flow. That is when renin is released. Renin will convert activate angiotensinogen, right? Angiotensinogen, it will convert into angiotensin 1, which in presence of ACE will get converted into angiotensinogen 2, and this is a potent vasoconstrictor. Okay, so this is the normal function. So when there is an abnormality here, when there is an abnormality in renal blood flow or renal functions and all, this is in turn leads to the increased release of renin and the increased vasoconstriction, thereby increased BP. Okay, so again, for hypertension management, we need the drugs which acts on RAS. Okay, so we have angiotensin ACE inhibitors. ACE inhibitors are there. Then we have ARBs, angiotensin receptor blockers, that will block the this receptors of angiotensin 2. Then we have direct renin inhibitors. That is a very latest one. Aliskiren. This is a very this was FDA approved in 2007. The studies are still going on this drug. Then we have diuretics, which you know how the mechanism is. So these are the and we have calcium channel blockers also. You know about that. So these are the main things. This any problem in the sympathetic nervous system or any issues with the renal blood flow or any issues with the RAS, then any issues with the hormone like hormones, thyroids and all, these are the primary etiologies or the risks factors which will cause a hypertension. Okay, so coming to the hypertension management, we basically follow the JNC 8 guidelines, which is the gold standard. So it was done in the 2014, the latest one. So maybe in the future there might come the new one. So right now I'll be talking about the JNC 8 only. So hypertension management, two things are very important. One is lifestyle modification, and other one is pharmacotherapy. Okay, so before that I want to talk about the goals. What are the goals? What are the goals in hypertension management? BP low. Okay, so achieve optimum BP. Okay, one thing which you have to do, and then another thing is prevent any CV complications. Okay, these are the important things which you have to focus. So achieving BP. So in JNC guidelines, what it says is regarding normal patients without diabetes mellitus, DM or CKD. In this patient, if this is greater than age greater than 18, okay, greater than 18, this guidelines is for the patients whose age is greater than 18. So patients without DM or CKD, if the patient is above 60 years, if the patient is 60 years or above, the BP target BP is less than 150/90 mmHg. See, diastolic blood pressure, it's the target DBP is 90 only for everything. Okay, you remember that. And if the patient is less than 60 years, then the target BP is 140/90. Okay, if the patient is diabetic patient without CKD, for all ages, there is no any differentiation like less than 60 or it will be less than 140/90 mmHg. Okay, if patient has diabetes mellitus plus CKD, then the target BP it is 140/90 only. Okay, only the thing is when the patient is greater than 60 years, if there is no diabetes mellitus or CKD, then the target is 150/90. Rest all it is 140/90 mmHg. Now talking about treatment. So first line agents, it comes as first line agents which we use are thiazide diuretics. Second line is first line, the other drugs are CCB, calcium channel blockers, AC is angiotensin converting enzyme inhibitors, AC inhibitors, and angiotensin receptor blockers. These are the first line drugs which are used in hypertension. So the studies or the guidelines, what they say is there is no preference of one other. I mean, you can't say CCB is better than thiazide or thiazide is better than AC. So all has equal priority. So the choice will depend on the patient's underlying conditions. See, again, the important factor which you have to note is the drugs will change based on the specific comorbidity he has. If for example, if he has a heart failure, then the drug In case of hypertension, general hypertension, they say that now the beta blockers are a second line drug, they don't use as a first line drug. In case a patient has hypertension, heart failure, then they will prefer beta blockers over the other drugs. So these choices will be covered in the other treatment guidelines. Now I'll be talking about these main drugs which are used. Okay, so yeah, these are the drugs first line. Second line, what drugs comes are beta blockers one, then aldosterone antagonist. Aldosterone antagonist. Yeah, these are the two drugs which comes in second line. The third line is loop diuretics. Direct renin inhibitors, that is the drug which I talked about, aliskiren. And clonidine, this centrally acting alpha 2 agonist. Then alpha 1 blockers like prazosin, terazosin and all. This comes in the third line agents. So first lines which we, okay, so yeah, now coming to this patients having DM or without any DM or CKD. Here we can, for both, it can be divided into two things, that is patients who are black and patient who are non-black. Okay, so here the interesting thing is, in the non-black patients we can use all the four. Okay, all the four. Okay, all the four drugs, anything you can choose. In case of black, you can choose thiazide diuretics or CCBs. The reason is, in black, the black race, the renin activity is below normal. So if even though you give ACE and ARBs which acts on the RAS system, so it's not so effective in that patient. That is the reason why we use why we don't use ACE and ARBs in black patients. Okay, this is the one thing which you want to remember. Then in case of CKD, the study says that ACE and ARB has a renoprotective nature, so it is preferred over the other two, thiazide diuretics and CCB. So in patient who are hypertensive and who has CKD, note the end stage, the normal the deranged CKD, you have to give ACE or ARBs. These are the preferred. Now coming to these are the drugs. Okay, I'll be talking about the ADRs later. So yeah, I'll talk about the ADRs only. So thiazide diuretics, what are the ADRs you will see? Electrolyte imbalance. Good. Electrolyte imbalance. Another thing is hyperuricemia are the things. So if a patient has gout, or if the electrolyte imbalance is a situation of electrolyte imbalance, then you shouldn't prefer thiazide diuretics. In that case, you have to prefer CCB, ACE or ARBs. For another thing, for ACE, when ACEs are not preferred in a patient, that is the ADRs. Yeah, I mean, when is ACE not preferred? Yeah, ACEs are not preferred in patients who are pregnant, one thing. Then another thing is hyperkalemia. If the patient has underlying hyperkalemia situation, that time ACE ARBs are not preferred. If the patient has peripheral edema or reflex tachycardia, so in that case CCP, calcium channel blockers, are not preferred. Okay, these are the things. Coming to the ADR, ACE, it has a dry cough, one thing. Then another thing is hyperkalemia, and another thing is it's a very rare thing, but angioedema. It has angioedema. That is one significant thing. In that case, if the patient has angioedema, then you have to definitely discontinue at that point of time. So you are not supposed to give ACE and ARB both. The dry cough is majorly seen in ACE and not in ARB. See, dry cough will occur because this ACEs will inhibit the breakdown or the breakdown of bradykinin, which will release the nitric oxides, which will cause. So that is a normal mechanism where vasodilation is occur. Then one situation, because the bradykinin levels will increase, this will induce dry cough. Okay, so that action is not seen in ARBs. So ARBs, so in ARBs there is no dry cough seen, but in ACE we see dry cough. Okay, another thing is hyperkalemia. Hyperkalemia is caused because ACEs will have these drugs will also have an little effect on the aldosterone activities. So when the aldosterone is inhibited, then the excretion of see what it does is aldosterone it acts on the sodium excretion, thereby this water will go out. Along with that, the excretion of normal function, there will be excretion of potassium. But when the aldosterone is inhibited, the excretion of potassium is inhibited, so there will be elevated potassium in the body. So that is how hyperkalemia is caused. So these are the things about these things. I mean, thiazide, CCB, ACE, ARB. Now coming to the drugs which are used, the dose and all. See, there are many drugs to choose, but one which we use in our hospital, I am talking about that. For example, thiazide diuretics, we have hydrochlorothiazides. Hydrochlorothiazides, the dose will be between 12.5 mg to 25 mg per day, OD dose. Another is indapamide, which is 1.25 mg to 5 mg max OD dose again. Then coming to ACE inhibitors, we see ramipril, enalapril. These are the commonly used drugs. Ramipril will come, the starting dose is 2.5 mg. The usual dose will be 2.5 to 20 mg. It can be given OD or BID. Another thing is, another drug is enalapril. The starting dose is the double of ramipril. You can memorize it that way. That is 5 mg. So the usual dose will be up to 40 mg, 10 to 40 mg. So this too again we can give as a OD dose or a BID dose. Then coming to the ARBs, we use majorly which drugs? ARBs? Telmisartan and losartans. Okay. So telmisartan, the starting dose is 40 mg. The usual dose 20 mg starting dose. The usual dose will be 20 to 80 mg we can give telmisartan, that is OD dose again. Then losartan, the starting dose is 25 mg. The usual dose will be 25 to 100 mg max. That too again it can be given OD or BID. Then coming to the CCBs, the dihydropyridines. Again, dihydropyridines will have more, ADR of this reflex tachycardia is seen more in dihydropyridine, that is amlodipine. So amlodipine, the normal dose is 2.5 to 10 mg we can give, that is again OD dose. CCBs, diltiazem, verapamil are there. This non-dihydropyridines. Verapamil will be like around 180 to 480 mg. So again it can be given as OD to BID dose. Yeah, that's it about the drugs. I'm not saying so much things about it. Another thing is lifestyle modifications. You have heard of a DASH diet, right? Dietary approach to stop hypertension. That is a one important thing in hypertension management. All this I said, along with this drugs which we use, the patient has to change his lifestyle, the diets which we use. So DASH diet, roughly briefly I will say, there should be increased fruits and vegetables. Okay, fruits and vegetables around 8 to 10 servings per day. That has to be your main food intake in the day. And the decreased saturated fat and cholesterols. Okay, so see how this act is, you need the one potassium intake. Okay, another thing is moderation or the limiting of alcohol intake. So that is one thing. So another thing, I mean, you have to, if the patient is a chronic alcoholic, you have to ask him not to take more than 350 ml of beer or 700 ml of beer per day. That is one thing. If the patient is not at all alcoholic, then suggest him not to touch alcohol. The another thing is smoking cessation. What else comes? Exercise. Exercise is another important thing which patient has to do. At least for 30 minutes a day. Every day he has to take. Every day he has to do, or else 5 times a day. But one more thing, when you suggest him to do exercise, you have to see that patient has no underlying causes which will trigger, like myocardial infarction or angina. So you have to be careful. In that case, in that patient, that is contraindicated. Yeah, these are the things which you have to look in hypertension. This is how you treat it.